everyone with an interest in NASH, or more broadly, fatty liver disease, Surf's Up, Season 4, Episode 42 of the podcast still known as Surfing the NASH Tsunami for a little while longer. Our review of last week's EASL SLD Summit starts now.
This week on Surfing the NASH Tsunami.
There's really a gap there, a group of patients that we do not completely understand, that we have been excluding from our research, also from not just the clinical research, but also from clinical trials. We have now a framework to tackle it better, to generate the data, and also to improve the management, hopefully, of these patients.
When I do and work with drug and alcohol, you tend to see more metabolic risks. They are more concerned about developing diabetes and heart disease than the alcohol effect on the liver. So maybe having that sort of element coming back into clinical to be able to target that population now is definitely a positive as far as I can see.
The importance of variability and getting it right becomes a lot more important if you're doing time sequencing than if it is if you're looking at a snapshot.
I would really like to see even more sort of non-speciality people coming to these meetings and being prepared to engage in the discussion.
That type of basic science is the academic justification to be there, because these academics are defining the targets and empowering drug developers, from my perspective, to hit those targets. And not every basic science model translates into clinics for its relevance, but I think it really helps us to move ahead.
Maybe it's time to start to develop something like metabolic clinics, where these patients get a one-stop shop and can get a full evaluation of their metabolic state, including the liver, the kidneys, the heart, everything.
Every week, a global community of fatty liver disease stakeholders comes together to explore the most important challenges in diagnosing, treating, and developing medications for patients with fatty liver diseases. Join hepatology researcher and key opinion leader, Professor Jörn Schattenberg, liver wellness advocate Louise Campbell, pricing and forecasting guru Roger Green, and their guests, hepatology researchers and key opinion leaders Sven, Francque, and Hagström, as they review highlights from last week's EASL SLD Summit on Surfing the NASH Tsunami.
Hi, this is Roger Green, host of the podcast still known as Surfing the NASH Tsunami. Because listeners responded so positively to last week's coverage of Paris NASH, which we did through a series of individual interviews, we decided to take the same approach this week with the SLD Summit. Monday was the Jewish holiday of Yom Kippur, so we were unable to record until Tuesday. We also decided to feature the same cast we had for last week's NAFLD Summit episode. We spoke with Hagström on Tuesday, Sven Francque on Wednesday. Unfortunately, Ian Rowe did not attend this year's summit, which conflicted with the EASL meeting. As a result, you'll hear from Sven, who, as one of the three people who organized the content for the meeting, has an exceptionally rich perspective on the agenda and how the transition from the nomenclature of NAFLD to the nomenclature of SLD broadened the aperture of topics to discuss. For that reason, we're going to take Sven's interview, which we did on Wednesday first, and Hannes' interview, which we did on Tuesday second. Sven giving you context about what they tried to do in the meeting, and then Hannes and Jörn and the rest of us talking about how well we think they achieved it. Answer, quite well. And here's Sven. And now we're here with our good friend, Sven Francque. Sven, good evening. How are you today?
I'm very fine, Roger. Thank you. Very fine.
And we've been talking about Sven's rather compelling travel schedule. Where are you tonight?
I'm in Amsterdam for the moment.
For 24 hours, right?
24 hours, yes. Very short, but very close to Antwerp, so it doesn't feel like traveling.
It's not far from Mainz either. I mean, that's the beauty about Europe, right? We're all so close together.
Yeah.
So from my side, Sven, to you and the co-organizers, congratulations to a great SLD Summit. I enjoyed it tremendously.
Mm-hmm. Yeah, it's nice to have this positive feedback. Thank you.
In fact, Sven, watching it on video, it felt different. Having been in Dublin last year, it felt different. It felt more energetic, and some of the topics felt a little more interesting and far-reaching. And Jörn made that comment yesterday, and so did Hannes. So as one of the folks who organized the meeting, I'm wondering what exactly how the nomenclature change, which yesterday Jörn and Hannes felt made a difference, and I felt made a difference, or anything else about the meeting plan might have led to having such a successful and interesting and diverse agenda.
there are, I think, several elements to it, because the nomenclature did incorporate it a little bit in the original program, but of course at the time we made the program we were not sure that the process would have been finalized by the moment of what then still was called the EASL SLD Summit. So until then we focused in the program, first of all, I wanted to tackle some subjects that usually are not that routinely covered in most of our NAFLD, now SLD meetings. Some aspects like the circadian rhythm, the sexual dimorphism, that kind of issues, and also the other organizers wanted to cover some points of discussion like the biopsy, the non-invasive tests, but not in the usual way, but really trying to focus on where are the current gaps in knowledge and how can we try to solve them. That was really what we wanted to bring into the discussion, really trying to identify areas where we still have a lot of work to do and bring the people together to discuss really how can we make things move forward, not just saying what's going wrong, but really thinking about how we can solve the problem. That was one of the main, what they say in French, fil rouge of the program. So that is really what we wanted to achieve. And it was quite broad. We had a very stuffed program. It was very charged, the program, especially on the Friday. We started early morning until very late in the afternoon. But also because we wanted to go from really a deep dive into the basics research and have the researchers together, bridging it to the clinical needs and then ending with the problem of awareness and the aspects of public health. Now, once we were approaching the summit, of course, we finalized the nomenclature process and we presented it at the Liver Congress in Vienna. And then, first of all, we decided with the EASL governing board to change the name from NAFLD Summit to SLD Summit, making it also a little bit broader in terms of topic. We had already a few issues on alcohol in the program, but we emphasized a little bit more on that, and that will, in subsequent SLD summits, be definitely a more important part of the program. And we also changed it a little bit, some of the lectures, and dedicated a specific session, not to the nomenclature as such, because that's what we presented already in Vienna, but to the implications of it and some controversial issues that come with it and how the research agenda should be moved forward by this new nomenclature. So I'm happy to hear that people felt it was different and felt that energy and that vibe in the meeting.
Jörn, happy to hear your thoughts on that first.
Yeah, I think we discussed that. The meeting represented the more broader theme we're seeing now in SLD, with making very clear that MASLD is the disease we've been studying all these years. All the evidence has been generated. MASH is the disease that we've been studying for many years with regards to steatohepatitis fibrosis, substituting for NASH. And I think that's very important to send that message and not get people that are outside of the field maybe confused. And it's still added in the reality that many clinicians always missed from us by separating the disease so strictly into alcoholic and non-alcoholic. So addressing the MetALD, there was a great summary session, talked about this previously before, and also the ALD field, looking at a continuous disease spectrum with multiple risk factors. I really like the pathophysiological session, Sven, the immune pathophenotype Matthias Heichenwilder talked about, but also some of the more exploratory studies, and of course the session we had towards the end discussing new treatment options. So I felt it was very round and continued and broadened where the field was left with NAFLD previously.
So Sven, which of the sessions do you think worked the way you had in mind? And were there anywhere, if you'd had more time, the agenda for that section might have looked a little different?
I think most of the sessions corresponded really to what we had in mind. Looking back at it, I think, but it's always a difficult balance to find, and there was already so much we wanted to discuss, but we also had abstracts that were sent in, and we had quite an important number. We had about 200 abstracts that were sent in, so there is a lot of very original research going on. We offered opportunity for a few to have a short oral presentation, but I think we could quite easily have broadened that and have a longer session with original original research, and because you have all those young researchers together, but also the experts in the field, we also had a lot of discussion about, what's the best animal model, what are the techniques, also things that we discussed. I think it would have been a good opportunity to bring those young researchers and those experienced people more together to discuss the research that is ongoing and the results that emerged from the abstract. So that aspect of young researchers presenting their abstracts not to a more general public like in the Liver Congress, but to really that group of experts that is together there, I think that could be very enriching also for those younger people.
I think that's an excellent potential to be able to do that, because the critiquing and the feedback that they would get would be beyond belief with all of the experts in the area, and that enhances the quality of the research that comes out of them in future years, which is obviously what we want. But I was unfortunate enough not to be able to attend the conference this time, but the energy that I'm seeing afterwards, and a lot of energy about the MAESTRO-NASH subcategory, that seems to have excited people, maybe because it's a more defined potentially area for research going forward. Did you get that sense, Sven?
Yeah, absolutely. We learned already after the launch of the new nomenclature that it created quite some energy in the field, and I think the fact that we clearly put forward, okay, you have a problem of steatosis, you look at the different causes that can exist, that can be combined in one patient. And we really should do the research now to understand, if you have multiple causes, how those causes interact, how they have most probably a synergistic effect and translate into a more rapid progression of the disease, and which is the predominant one and which is a contributing factor. So I think it really now gives a framework to do that research. We all know that it's a clinical reality, and we do have a few data from an alcoholic liver disease where you see that metabolic risk factors still modify the risk of progression of the disease, but there are very few really high-quality studies out there. And on the other hand, in the NAFLD research we have been doing so far, we have excluded patients with alcohol consumption. So there's really a gap there, a group of patients that we do not completely understand, that we have been excluding from our research, also from not just the clinical research, but also from clinical trials. So yeah, I think it's really something that will be, we have now a framework to tackle it better, to generate the data, and also to improve the management, hopefully, of these patients. Once everybody realizes that we need to tackle the different risk factors, and we have to keep an eye on the different risk factors of disease progression, and not just the one that is, of course, predominant, but not to forget the other ones.
No, and it is interesting. In clinical practice, when I do and work with drug and alcohol, you tend to see more metabolic risks. They've already got AF, or they've already got diabetes or pre-diabetic, whereas the liver itself isn't showing any signs of fibrosis. But they are more concerned about developing diabetes and heart disease than the alcohol effect on the liver. So maybe having that sort of element coming back into clinical to be able to target that population now is definitely a positive as far as I can see.
Mm-hmm. I couldn't agree more, Louise. Clinically and by the way, in research as well. So Sven, one of the things we talked about a little bit last night, yesterday with Hannes, I think it started with an observation from Jörn, is that a lot of the biggest challenges we've had to date stem from creating ordinal variables or nominal variables that we treat as being really powerful and important, right? Mm-hmm. Ballooning is one example, but another one is the continuum from alcohol to steatosis. My feeling was that the NIT session, in fact, obviously talked a bit about the issues around ballooning and ordinal as well. Where do you envision will be the proper place going forward for those discussions about how do we do a better job of creating continuous variables that capture the reality of the disease? If you put it on a continuum from alcoholic to steatotic, variables that capture the continuum of the disease, because MAESTRO is somewhere in the middle. Well, actually, it's a question. Is MAESTRO somewhere in the middle on a single continuum, or are they really, is it really a XY axis kind of a thing, do you think?
Oh, the MAESTRO, of course, is still a category, but I think that the understanding, we have always known that everything is a continuum, and we put it into simple categories in order to be able to work with this. But that's a very oversimplification of a very complex reality. But yeah, you need some more simplistic tools to be able to work with in clinical practice, but we have also learned that this has many, many, many limitations. And I think that with all of course, you can talk a lot about AI and it's fancy, but it's also a reality that we have now more powerful engines to work with continuous variables and to learn to work with them. So I guess we will have to learn better understand how all these things are in a continuous spectrum. The problem with many things is that, of course, you have an important variability in whatever you measure. Differences between labs, differences within patients if you measure it today or tomorrow. So there are several things that we still need to understand better to capture that variability and to understand how we can work with that in clinical practice, because it's good to have continuous variables, but if there is variability and the measurement of today is not the measurement of tomorrow, how will you then make an interpretation of a measurement in 6 months? And how can you be careful enough to not to have a wrong interpretation because you ignore all the methodological issues that come with these parameters? So I think that all the techniques of artificial intelligence and what comes with the possibilities to work with big data will help us to improve on that. But still, we have a lot of work ahead of us. We're just at the start of it, I think.
I agree with Sven, Roger, if I might say. The complexity also adds in that drinking is a social aspect in many of those MASLD patients. They're not alcohol dependent, and as such, the social concept of drinking on certain days, but not on others, reminding themselves to cut down on alcohol consumption over a certain time, then falling back, it might make a difference in certain people. And that's one of the reasons why I don't like the daily consumption concept. In my patients, I typically try to go weekly to at least have the weekend, but that falls short in some patients, of course, too. So there's variability to the MASLD group. That's why, from a drug developer perspective, I understand why you say this is a little more difficult, but it's very important we're moving there. And I think Sven highlights some very interesting aspects using computer-supported AI to better grapple with these categories, and the only importance is, are they different in outcome? And I think we'll be able to understand that.
It's a good point. The one other point that Sven made that I keep forgetting, and thank you for reminding me, Sven, is that unlike viral hepatitis, where if you can start to treat the virus over time, you can predict a path that things will go down if you treat it successfully. And that path will be headed in one direction. It might be linear, it might be curvilinear, but it's going to be headed in only one direction. The variability around fibrosis and steatosis in a MASH patient, or MASLD patient, I would guess, is considerable. So Sven's point about you've got to measure all these things over time, I think really matters, in particular when you're dealing with continuous variables. And I like your question, Sven. I appreciate your question about the importance of variability, and getting it right becomes a lot more important if you're doing time sequencing than if it is if you're looking at a snapshot, which is where it sounds to me like we're headed. Yeah, but we still have an awful lot of work to do. So we will not be out of work. That's why we are in science and clinical science. The other thing that struck me was there were at least 2 sessions, one being the one on Saturday morning that Jörn discussed with the different modes of disease, and then the one on Friday afternoon on the novel techniques for basic science. That my feeling is, as money comes into this specialty because drugs get approved and investment goes up, those areas should just explode over the next 5 to 10 years in terms of how much research can be done. Fundamentally, each of those papers could turn into a section 2 years hence.
Well, I can only hope that there will be indeed a huge investment in high-quality research, and for sure if we have drugs that are efficacious and that can make it to the market in the end, I think that will hopefully help in funding also the research, not just the pharma-driven research, but also just our understanding of the disease.
Look, we're still dealing with a disease where the best drugs are reported to have 30 to 40% efficacy. That will be a message to pharma that basic science needs to be far better understood so that we can come up with drugs that help more patients. Or a set of disease classifications or subcategories.
Yeah, it's absolutely that disease heterogeneity that we need to better understand. It's fancy to talk about personalized medicine and whatever you want, but as long as you do not understand the heterogeneity of the disease, that's a nice word, but you don't buy anything for it. But the opportunity is there. I mean, with all the tools we have, I think we can go in the next 5 to 10 years way further than what we have been doing so far. To understand the heterogeneity of the disease, because The pathophysiology is probably very different from one patient to another. And that does not invalidate all the research that we have been doing. It has been a great effort to gather all these data, but it's time to take the next steps.
That makes good sense. Sven, what research did you share at the meeting?
We talked mainly about the vascular mechanisms. It's a long-standing interest of us. It's studying how changes in the endothelial function, not just endothelial, but the whole vascular biology of the liver is something that seems to occur already early in disease and probably contributes to disease evolution. And it's also for the whole spectrum. So it's also relevant once you get to the advanced stage of the disease and what we're still calling cirrhosis, where also the vascular mechanisms and the mechanisms of portal hypertension seem to be different in this disease if you compare it to alcoholic liver disease or viral liver disease. So we, in my talk, and also one of my co-workers had an invited talk, we mainly discussed those vascular mechanisms, and Professor Pierre-Emmanuel Rotou from Paris, Bourgeon, also discussed data, clinical data on early signs of capillarization of the liver sinusoids in patients with MASLD NASH. So both the basic and the clinical data were covered, but we also presented some data on a cohort of our center with about 126 or 25 patients that had portal pressure measurements by HVPG from the whole spectrum, so not necessarily patients with cirrhosis, showing that even in patients that do not have cirrhosis, you have patients with elevated portal pressures, even in F0 to F1. Now, the portal pressure is...
Oh, really?
Yeah, portal pressure in these patients is only very rarely elevated above the 10 millimeters of mercury threshold for clinically significant portal hypertension, where they do have some degree of subclinical portal hypertension, meaning that there is an increase in their intrahepatic vascular resistance. And that is more pronounced once you get to the more advanced stage, but it's not restricted to patients with cirrhosis. And that is not just a sampling variability issue of the liver biopsy. We also looked into other parameters, and these patients clearly with elevated pressures, for one or two exceptions where based on imaging you could suspect a cirrhosis, but the other ones were clearly non-cirrhotic patients, also with other tools than just the liver biopsy.
So you said more frequent than F0 or F1 even, that's the sub 10 millimeter level. What proportion of those patients exhibit signs of that at a sub 10 level?
Well, if you put them into two categories and you separate the cirrhotic ones from the non-cirrhotic ones, in the non-cirrhotic ones it's about 1 out of 3 that has an elevation of portal pressure, but as I said, very rarely it's above the threshold of 10 millimeters of mercury. So about 2/3 they have a normal portal pressure and 1/3 has an elevated portal pressure. When you look at the cirrhotic population, of course, the vast majority has some elevation of portal pressure, and quite a substantial number has clinically significant portal hypertension.
So let me ask my colleagues before I ask you, if you knew that an earlier stage fibrosis patient had elevated but not 10 millimeter elevated portal hypertension, would that change at all how you thought about treating that patient or advising that patient?
That's the next step. I find I found this data very interesting, Sven, I have to say. Congratulations. It addresses some of the pathophysiology of the disease that we don't understand well. I think with potentially fat, alternating blood flow, capillary blood flow is my understanding. Not sure what you think. It's not the same phenotype as we see in cirrhotics, because there the distortion of the liver tissue is, of course, something to a much bigger extent. But it could be a subgroup of patients that has a different prognosis or different treatment options, and that's where you're coming in, Roger. I would think, yes, this is something that should be corrected if it's pathophysiologically relevant to these patients. The question is, how do we assess this non-invasively? It brings us back to an old discussion in the MASLD field.
Yeah, I think Jörn is absolutely right. The diagnosing this clinically is for sure challenging. Personally, what I take from the research that we have been doing so far is that these mechanisms are probably contributing to disease evolution, and we should not forget that also, Roger, you talked about viral hepatitis, and we know that if you have viral eradication, there is a tremendous improvement and regression or even disappearance of fibrosis. But what has also been shown is that some aspects of alterations of the liver vasculature, like the capillarization of the endothelium, is something that tends to persist even if fibrosis regresses. So it's a kind of lesion that seems to be more resistant to regression in other diseases. It has not been studied so far in FLD space or the MASLD space. But we should be careful because we've seen with tackling the metabolic drivers of the disease that you have a substantial, or you can have a substantial improvement, but not all patients respond, and especially when you have more advanced fibrosis. With the pure metabolic approach, you don't see any significant results on regression of fibrosis, probably less progression, so there is also a signal, I think, on fibrosis, but not very strong on regression of fibrosis. So we should really make sure that we are not overseeing changes that are probably not so reversible as some of the other aspects of the disease are. Another aspect, and it was touched upon a little bit by Arun Sanyal, who gave an excellent talk on the first day on NASH cirrhosis or MASH cirrhosis and the challenges we have. And he also tackled the aspect of vascular lesions in these patients. He even said that he tended to start thinking that MASH cirrhosis was a vascular liver disease, showing the importance of the vascular mechanism. But he also showed the data that has been gathered by groups where we also participated, that the portal pressure in, as I said already, the mechanism looks a little bit different, and there might be a pre-sinusoidal component to the portal hypertension, making HVPG even underestimating a little bit the real portal pressure in patients with cirrhosis, because we could document that for the same amount of elevation of portal pressure as measured by HVPG, you have a higher rate of decompensation and mainly ascites in patients with the MASH cirrhosis. And also a study in TIPS, but that was not a study where we participated, showed that there was some disagreement between HVPG measurement and direct portal pressure measurement at the moment of the placement of a TIPS in patients with MASH cirrhosis, which was not the case in patients with viral hepatitis-related cirrhosis or alcohol-related cirrhosis. Pointing again towards the fact that, and Jörn rightfully says, once you get to cirrhosis anyhow, there is an important distortion of the architecture, including the vascular architecture, but it does not seem to be completely the same in MASH cirrhosis compared to those classical sinusoidal portal hypertension etiologies.
So I understand that your graduate student researchers will have a lot of work to do in their careers. Yeah?
Absolutely. But I'm a little bit biased because it's my topic for many years.
Yeah, but it's an important topic.
It's a fascinating topic, yeah.
Either of you folks have any questions, or first of all, Sven, as Jörn already said about your work, congratulations on a fantastic meeting, and I think really broadening the boundary, a program that broadened the boundaries.
Okay, thank you. Nice to hear that.
For future events, I thought that was fantastic. Jörn, Louise?
I did have a question. Sven, have you done fasting, non-fasting FibroScans in that population? The reason I ask that is we used to do a real-time FibroScan clinic and only bring the ones back who had elevated KPA. And when we reviewed them, the average movement in the KPAs was 4.5 kilopascals, and it was actually around 100 in the 1,000 patients. And the CAP score moved 0.08. But in some of those that we looked at who'd had the kilopascals shifted, where they'd had a biopsy, they only had sinusoidal changes. So it looked like the potential to detect that mild gradient shift with kilopascals, which is a pressure measurement. And as we know, the liver shouldn't stiffen up when we eat. The blood flow should still be nice and soft throughout the liver. But it's whether or not you can detect it in fasting, non-fasting, because you actually increase the blood flow and the peripheral resistance.
I must say, Louise, this is an excellent idea that you bring up. We didn't check that. We do the FibroScans always in the fasting condition. What we did check several years ago was just in those that was in healthy controls, what the difference was. And you have a small difference of 1, 2, up to 3 maximum kilopascals. But it might be indeed that this might be more pronounced in this population due to the sinusoidal alterations. Yeah, it's absolutely, we didn't investigate it, but it's an excellent idea. But as Jörn said, we're absolutely struggling with how we can have, let's say, quite accessible, safe, easy tools to measure something like that, because we did it with HVPG measurements, and that's all very nice, but that's not something you can apply to routine clinical practice. It helps us generating these data and it advances the research, but it's not something you can do later on in routine clinical practice, that's for sure. No, it's an excellent idea. Thanks.
Louise does that from time to time, like every other week.
I'll be on the paper.
That's great. Well, now that she can put FRCP after her name, she lends an added penumbra to every paper she's allowed onto. Jörn, you have anything else for Sven today?
No, I think many things covered. Looking forward to see this evolve in the future. Again, broadening a little bit without losing the focus of having a druggable disease with a clearly defined approval pathway. We're not talking about different diseases here. We've generated so much evidence, and I think SLD Summit brought this forward.
I agree more. At the intersection of a druggable disease with needing data and then the need to understand what's going on beyond that, because the drugs we have right now, even the best of them, don't help enough patients enough for us to be satisfied. I mean, there was a point in time where people said there would not be any new antihypertensives for the next 25 years. We're nowhere near that here yet. We don't even know what we need to know to get to that point yet. So Sven, thank you so much for joining us, and congratulations again on a fantastic meeting. Bye-bye.
See you.
Bye-bye.
Before our second interview with Hannes, I have one point to make. I strongly request you listen to this week's business report. We've got major news about changes in the podcast going forward, which I believe you'll want to hear. So stay tuned. And here's Hannes. So, folks, we're so positive about what we did last week, putting 3 individual interviews with Jörn and Louise and me together, that we're going to do an abbreviated version of that this week. If you recall, last year we did our session right after the end of what was then called the MASLD Summit, and we had Hannes Hagström and Sven Francque and Ian Rowe with us. Ian was not at the meeting this year because it conflicted with the BASL, but today we have Hannes, and tomorrow we'll have Sven, and we will put those 2 things together. Let me also note for everybody that you're going to want to listen to the business report because it's got some important stuff about the future of the podcast in it, maybe including some teasers on the name change to be determined. So, Jörn, you say you came back with sniffles, huh?
I would say I came back full of energy, thinking about SLD. So I have to say EASL Summit was a little faster than this podcast, new name to the conference. And I think I felt it throughout the entire program that this is really innovation moving forward. So lots of energy coming back, and congrats to Sven Francque, Sophie Lothartstian, and Jeff Lazarus, who were the course organizers. I felt it was a big success there.
Yeah, I agree. And redeeming the thing that I personally found most compelling about the nomenclature change was the idea of a MedALD session, one of which there actually was. I think that was, when you talk about stepping in quickly, Jörn, it's not just the name change, it's then just getting the focus aligned as well. I thought they did a great job at that. Completely agree. Hannes, how are you this evening?
I'm great, Roger, and happy to be here again.
Welcome back. Hannes is fine. He has a slightly ill family member, sniffles or something like that. So I may be the only one in the household where everyone's healthy. I haven't checked with Louise yet. Louise, how are you this evening?
I'm very healthy, thank you very much. No sniffles, no grumbles that I can complain of. So I'm good. And I'm back in the UK, as you know.
And Louise and I were texting throughout the day on Sunday because in the Premier League, the 2 marquee matchups of the day on Sunday were hers and mine. And Liverpool disposed of West Ham pretty handily. Tottenham went into Emirates Stadium and got a draw with Arsenal, which is a stadium we've not won in 30 years and have only drawn 5 or 6 times in the interim. So I think we were all happy, huh, Louise?
Yep, Robert Mitchell-Thane won't be happy, but...
No, he won't. And Jörn, the English captain, got his first 3-goal game at Bayern Munich.
Is that right? It's great to have always a soccer update here with you guys, so... guess I missed that part.
Harry Kane will be one of our own for as long as he plays, unless he comes back to the Premier League for somebody else. So I will follow him and keep you updated. With that, why don't we dive right in? We're anticipating 30 or 40 minutes for this conversation and probably similar length for Sven's, and that will be our episode. Hannes, let me start with you. Since we've last seen you several months ago, what are the most exciting project or 2 projects that you've been working on recently?
I can only do 2. Well, so we have a lot of stuff coming up this fall. Hopefully that will be published. Well, I can mention one thing we presented at the SLD Summit, which is something called a target trial. It's a pretty new way to use observational data to emulate a RCT. So it's been shown to perform considerably better when you benchmark the results from observational studies to that of sort of pure RCTs. And that has to do with the statistical methodology that's been used in this design. And so we did this for obviously then an interesting topic in hepatology, which is GLP-1 agonists risks and progression of chronic liver disease. That was presented at the SLD Summit, and I don't know, that's something quite interesting, I think.
Okay, and then outside of work, what are you looking forward to the rest of the year?
So I actually mostly looking forward to some snow and to go skiing, but probably that will be start of next year and not this year.
Okay, that'll work. So with that, why don't we just go do groundbreakers, okay? One good thing that's happened in the past week, and then I'm going to ask Louise and Jörn and myself to do the one thing we're looking forward to the rest of the year as well. Brave one, go first.
I can start then. So I just came back today we had sort of a small competition in Stockholm, in the region, where sort of projects that were deemed to be innovative by the city council were awarded or had a competition. And we were the second place in the implementation sort of prize for a study we have just finished, where we have done FibroScan in type 2 diabetics in the retina scanning facility. So instead of sending out the FibroScan to all primary care centers, we put one in the retina scanning facility, where all the type 2 diabetics are referred with regular intervals anyway. So I was we got second prize, but I was a little bit, of course, sad we didn't get the first prize. But the first prize was some persons who had done a study in sick kids, and they always win.
Well, yeah, sick kids are a great currency for that kind of thing. So next year, you've got to figure out how to do a study in sick kids with or adolescent or pediatric SLD.
We have to transition.
He could base the FibroScan in a dental surgery.
Ooh.
Because where do children go with bad teeth? And why do they have bad teeth? And you will nail it, Hannes. You'll nail it.
There was actually another study that looked at sort of screening for type 2 diabetes in dental clinics. So why don't we piggyback on that and do a liver scanning as well?
Mm-hmm. Yeah. So Louise, when it's 7 o'clock in the evening where Louise is as compared to somewhere past dark 30, she gets all kinds of energy. That was fantastic. Very, very good. Who wants to go next?
Oh, I'll jump in next. I was interviewed for something called Woman of the Week last week, which we are putting out on the 4th of October for October's is for Liver Month, because it's all about liver health. But it's a philanthropic sort of LinkedIn magazine about motivating women and women in leadership and women in their careers. I don't know how they picked me, but they did. So I think they pre-seed it down to 500 words. So that'll be an interesting release. And it was quite fun to do. So that'll be my positive or my highlight of the week.
That's fantastic.
Congratulations. You've been on such a roll this month. You've been really doing great things. Rest of the year.
It was funny. The last question is, who would I nominate as for Woman of the Week? And I did have a few thoughts, but I nominated Donna Cryer. Obviously for all of the things that she does. Whether or not she chooses to be interviewed, I don't know, but for a motivational woman, then there were a number, but I went for Donna.
That's great. Did you get this because somebody nominated you, or just do you know how they came to you?
They came to me for that. So I think it was Maggie Philbin was done last week. So it's usually influential women. Okay. So I don't know why they came to me.
We think you're powerfully influential, so that's a good thing. Jörn, go ahead.
Yeah, well, fascinating Sunday. Family history again. My 8-year-old is playing a round of tennis. So over the summer, they played 8 teams and won all matches. So they were prized with a tennis, let's say, a cup in that age group. And we had a little celebration barbecue with all the kids. So clear highlight for me after returning from SLD Summit.
I guess my highlight this past weekend was we went to a friend's surprise 70th birthday party, which is why I was playing catch up on the summit. In fact, it was really kind of an interesting thing. He had 3 generations of family members and friends, and there was threatened stormy weather where we were, but the storm wasn't bad. I got to do something I'd never done in my life called candlepin bowling, which is only known in New England, but it was a good time. And now I'm back here, which is a good thing. We're all back here. So with that, why don't we dive in? Jörn, you alluded to this briefly, but I'd love for you to elaborate, and Johannes as well. How did the meeting feel? And specifically, did it feel different than the NAFLD Summit did last year, besides the fact that Dublin and Prague are very different cities?
I'm going to start and see what Hannes thinks. For me, the meeting was under the impression of the name change, and there was, of course, a nomenclature debate and an opening. It wasn't a debate. It was, where are we today? And steatotic liver disease, the problem to solve. So at many levels, there was steatotic liver disease at the center of this discussion. Alexander Francque came up to discuss alcohol and MASLD in one discussion. So to me, it felt very prominent. We're not leaving MASLD, but there is a clear tendency to, from the academic side, wanting to address that population that might have different outcomes. Now, if you're on the drug development side, maybe I heard some struggling. How do we place that? How about the regulatory context of this? Can a drug be approved in such a population? population? How are they different? So I think there's a lot of things to be sorted out in the future, also with the regulators. But this is something where academics, of course, come in and define the cohorts and, work like Hannes has access to those large longitudinal databases showing differences in mortality. And my expectations would be that there is incremental damage to the liver through the different MASLD categories as good as we can define them today. So it'll be interesting to see that moving on. And the one talk I specifically want to highlight is, of course, a very forward-thinking, state-of-the-art MASH cirrhosis talk given by Arun, but we can talk about that down the road, I think.
Yeah, I agree. I think it was a lot of energy during the meeting, and these sort of smaller meetings are always maybe better for that, to really get the discussion going. There were 3 things I think are sort of discussed now, these later meetings, with a more sort of open mind that maybe was done before, and that is, as you alluded to, Jörn, the relationship with alcohol. It's really the sort of elephant in the room, and we have sort of just closed our eyes and ears to it previously, but now we are starting to acknowledge that, it can be a problem for some, and you need to consider it when you do both observational research and do clinical trials, because it's such a strong cofactor. And now we have biomarkers that makes it very simple to at least exclude those with high current consumption that we might have a difficulty to do otherwise. The second thing I thought we sort of discussed a bit more open is of course, which we have also done before, but the problems with biopsy. It's more of a silver standard, and that the non-invasive biomarkers that we have, it's difficult to know that aren't they really better than the biopsy. They referred a lot to Vlad Ratziu's previous study where he found that if you do 2 biopsies at the same time in the same patient, also fibrosis can be quite different in different parts of the liver. And then the third thing I reflected on was we are sort of coming out of this categorization of everything. We as humans love to categorize everything, yes or no, or 1, 2, 3. But now we are discussing more openly that, it's actually a spectrum that we are measuring, and that goes for both biomarkers, for how we classify NASH and how we classify fibrosis. So I think we are on a good path.
Let me just add on. I think that's a crucial comment that Hannes here made, because the disease is a continuum, and we felt that in various discussions. But to draw a line and talk about black or white, primary endpoint achieved, yes or no, you got to go binary. And whenever you draw a line, you enter margin of error. And we've been fighting around the margin of error for some time now, and I think we've become very good at reducing it, but it's not going to go away as long as you're still binary in a continuous disease.
Yeah.
You know what, Jörn, that's kind of interesting, because one of the problems with the biopsy scoring is it's nominal, right? Which isn't a lot better than ordinal exhibit. Well, actually, same thing as ordinal in that regard. So if you wind up making MetALD a third nominal category, have you made the problem better, or do we need to go further to actually get the spectral nature of the disease captured?
So this is, of course, tricky. And even if we got a biomarker that is continuous, such as PET or glucuride or whatever, then you always have some degree of measurement error, and you can't really measure anyway what happened 2 years ago. So we still have to do medical, decision making, and that's really the problem. Even if you know that something is on a continuous scale, as you say, Jörn, you still need to sometimes make a decision. Do you treat or do you not treat? And maybe a fourth reflection I was taking away from this meeting is that we start to talk a little bit about risk now, that we as hepatologists have maybe wanted to classify everything as yes or no, and we want to find everybody and want to treat everybody. But sometimes, and that has maybe Ian done a lot of work with, maybe we need to, in this very, very common disease, go towards a risk estimation that this patient has a certain risk for developing liver-related outcomes within a specific time, and that is enough for us to treat. But where the threshold is going to go, that will also depend probably on what drug can we offer to patients, what are the side effects, and so on.
Interesting. So, Hannes, it would seem to me that the kind of databases that you develop and work with would be set up really well to help solve that kind of problem, yeah?
Yeah, hopefully what our strengths are is the longitudinal follow-up, of course. So we can probably quite easily do phase 4 trials when we get drugs on the market to see what happens to the patients that are exposed to these drugs. But Sweden is a small country, so maybe it's not the best country to do big trials in. We have a sort of not as high prevalence of obesity and so on, but we do have this capacity to follow everybody for as long as you live.
That's a great point. And coming back to one of the presentations you gave, the target trial stimulation, my understanding is that you can, by increasing the number, stimulating real world, basing on real world data, you can predict outcomes, or you can come up with response rates that otherwise might not be available at that treatment number. And I think that's one way to augment clinical development. And I think we'll see more use of that. So very forward thinking. Any comments?
So is your database organized in such a way that with that kind of thing like target, that MetALD becomes something that you can attack a little bit earlier than other people because you can go back? I mean, does your data allow for that?
So when we work with our main registers, we do have access to these codes that we as doctors make when we see patients. So we can, of course, identify patients that have both coding for MASLD and for alcohol-related liver disease. And that was actually a poster we presented at this meeting. So around 18% of patients that have a NAFLD code, which is the current way we code, at some point in their life, they're also given a code representative of a high alcohol consumption. And those patients that do so, they have a much higher progression to cirrhosis, 3 to 5-fold higher than those with sort of pure MASLD. But if that really corresponds to MET ALD or if it corresponds to wrongly classified ALD, that's of course a bit less possible to know. The benefit with our large-scale data is that you get very high coverage, so very little selection bias, but you lose the granularity because you don't have access to patient charts. And there's always the risk that some doctor have made the wrong diagnosis, of course.
Excellent. It does seem like a head start and certainly an area that's going to be important. Jörn, you want to tell us a little bit about mitochondrial uncoupling?
Oh, yeah. So that was the last day, the last session. And it had an interesting title. It said something like Beyond the Usual Suspect. That's what it's called. It was chaired by Manolis Tsoutsoutsis and Francque. And it had 5 talks in there, I believe. Phil Newsom was talking on cell therapy. Interesting recap. Some of the mesenchymal cell transplant experiments that didn't really show full success. However, he alluded a little further in his own data on transplantation of monocytic cells. So I felt that was interesting. And the way he positioned it, there's some promise in there. I think we can be on the lookout. There was a session on ammonia. Debbie Shawcross, she's the incoming EASL president. And it was interesting because she said in the non-cirrhotic patients, we do see some mental impairment based on ammonia levels. And that's, of course, pathophysiologically something as a hepatologist that we understand. The interesting question is, why do they develop that? And why isn't the liver clearing that if it's non-cirrhotic? It gave some food for thought. So I think this is more at an academic level. That was me talking about the mitochondrial uncoupling. And I revisited the concept of mitochondrial uncoupling that's even today being used illegally, if you'd like to say so, as a food supplement to lose weight, and particularly lose fat, because what it does is it leads to inefficient ATP synthesis. As such, you generate energy or heat instead of ATP, and you can increase your energy expenditure. In the context that it was used in the clinical trial, it was a specifically designed molecule where you avoid peak levels and rapid absorption, and as such, avoiding unwanted side effects like pyrexia. And here at EASL 2022, Mazen Nuradin presented the phase 2A data from a trial where they showed very effective on fattening within 60 days. My conclusion was that you have to be, of course, careful if there's a side effect of the substance historically. It wasn't seen at this time, and it could be something that for a limited time moving forward seemed very safe and very effective in defattening the liver. So the phase 2B is ongoing, and we'll see where that leads us. Yeah, and just to finish off the session, I think Luca Valenti talking about gene targeting, very exciting area also. Between cell therapies, ammonia, mitochondrial uncoupling, and genes, we're going to see some of those suspects emerging in the future as therapeutic, more robust therapeutic interventions.
Jörn, when you talk about the energy in the meeting, one of the things that struck me as energizing was that session and several others that really didn't come with answers, but came with questions or progress reports that weren't quite ready. I mean, things that aren't quite ready for prime time yet, if you will.
And it was. And I missed Gertrude Mingrona, who has a huge bariatric surgery session, and she presents some data on the weight loss independent mechanisms of these bariatric surgeries. And again, that lines well with a session I did on bariatric therapy. Still the concept that we can use weight loss and weight loss independent treatment effects from those bariatrics therapies, and we can learn something in the field. I thought that was interesting.
Can you summarize what we can learn in 30 seconds or 2 minutes or some reasonably short period of time?
We're heavily discussing weight loss these days, but clearly, in particular in the advanced disease stages, we'll need more than weight loss. So while very effective weight loss drugs might cure a lot of the F0, F1 MASLD treatments, we'll be looking at liver-targeted specific therapies that could come out of the realm that I discussed, that could come out of weight loss independent effects we're seeing with those weight loss inducing agents, let's say glucagon receptor activation in the liver, but we'll have to understand that better. And as such, I think there is still a lot of room independent of all the progress we've made with treating obesity in these patients. And I think that last session gave us a lookout on an idea of what might be coming.
That's exciting. Louise or Hans, any questions for Jörn about that session?
No, I think it was a very interesting session with a lot of novel therapeutics that might come up. I'm always a little bit afraid that we will have to do very expensive drugs in a very large population. But if we, as you say, Jörn, can narrow down the population that we want to treat with these more expensive drugs, then perhaps there's a role for them as well.
My main question question was, I got a sense, I didn't attend the meeting, but I got a sense from looking at social media, there was a more diverse audience. The Society of Obesity were tweeting, so they were obviously present. I wasn't sure how diverse the audience were, but it was really nice to see other societies who are our co-partners in these diseases weighing into steatotic liver disease on the positive and how it can help and change their community. Was there a feel that there was a different dynamic in the room?
Louise, you're talking about the different dynamic among the different stakeholders.
Yes, there seemed to be certainly more visible presence from those outside the meeting, like myself, who got it on Twitter and things like that. There was a bigger stakeholder presence there than maybe at Paris NASH, for example, because that was only a couple of weeks before.
Yeah, so I think you can't compare it with Paris NASH because it's a specialty meeting. EASL SLD Summit clearly has a bigger footprint. I watched the first session given by Matthias Heichenwälder on the immunophenotype of HCC and MASH from the car driving from the airport to the meeting, and it felt like I was there. So the opportunity to follow through the web stream, I think, opens up this to a larger crowd, and you have a larger uptake. I'm going to be excited to hear what Ian thinks because he wasn't physically attending, but I think he went back and maybe saw some of the sessions. So in general, I would say yes, it's still a liver-heavy crowd, so we haven't had cardiologists attend, but the EASLD Summit is clearly a highlight, and I think in its next version is going to happen in January 25, so we're going to have a year of pause in between, and there will be a lot of things coming up in the meantime. So I think it has a special vibe.
Are they stealing the hashtag Go Skiing strategy or January for a different reason?
I don't think they've arrived with hashtag, but...
It's going to be interesting when they wait a year, given resmetirom and other medication. We may have two medications available then, and we'll know how expensive they are or not.
Yeah, well, Hannes, you said maybe to Louise's question.
So I feel like the cynical guy now. Sometimes I feel it's mostly the same people talking, coming up and putting questions out to the speakers and so on. So I'm actually looking forward to this field being wider. So we have a sort of a more nuanced debate and also taking in the opinion. I'm always sort of lacking a little bit, the perspective of primary care and endocrinologists and so on, the people that we will probably need to work much more with. What are their impressions? There were some comments at one of the sessions from a surgeon, so that was nice to see, but I would really like to see even more sort of non-specialty people coming to these meetings and being prepared to engage in the discussion.
Hannes, it's an interesting point you make. One of the things that struck me from the program, and this was a session I'm planning to take a look at tonight or tomorrow, was a lot more emphasis on cardiovascular than we've seen in previous meetings now. I think that kind of goes along with Mosaic being a thing now in the States, and the shift to metabolic focus. I expect we will see more of that. I've teased Jörn that he's clearly become an endohepatologist at this point, maybe even an endogastro-cardio-hepatologist, depending on the day you talk to him. I thought this, by the way, I'm just testing this impression, I thought the speakers were a little more diverse geographically than what I remembered from last year. Australia, Eastern Europe, was there anywhere for South America? I don't remember. But possibly a slightly more diverse group of speakers, although, honest, I take your point about where the questions come from. Did you get that sense in the meeting, or was that just me reading the program without context?
Yeah, I mean, you probably have a better sense of what it was looking like last year as well. So completely agree. There was a lot of people from outside Europe coming to a podium and speaking. So that was also, of course, very nice.
Personally, one of the sessions that got my attention was this is a work in progress, was this, it was kind of that piggyback thing, right? The special techniques with the promises and pitfalls in MASH, followed by a 25-minute talk on liver organoids and MASLD research. I thought each of those presentations was fascinating. The second one was, they changed who the presenter was and what the presentation was. And of course, Neil Henderson chaired it, and I could listen to Neil read a phone book. Louise, of course, always talks about Neil's entry to the podcast. But I thought his verdict at the end, which is we're making a lot of progress, but it's not clear that any of this is quite ready for prime time yet, was exciting. Really, it sounds a little bit, Jörn, like the session that you did, except on some basic science techniques as compared to categories of therapy. There were 5 papers. Neil talked about spatial transcriptomics and fibrosis. Maurice Peisler talked about intravital microscopy and cell trafficking and inflammation. The third talk was not the one that's titled here and was given by someone else from Berlin. I'm forgetting the talk. Then one on immune cell phenotyping from Charlotte Scott in Belgium. And then the 25-minute talk at the end was titled State-of-the-Art Liver Organoids in MASLD Research for Mechanistic Insights for Drug Testing. That was a talk from Leo van Grunsven from Brussels. I thought that was really fascinating. And as I say, all these things are in various stages of development. It sounds like they've each got work to do. But we're starting to see maybe a bit of a bifurcation between NITs, that will be good for drug development once you know what the drug is, what you're looking for, and basic research?
Let me just comment, Roger, because I think a lot of the drugs we're developing from the metabolic space and the diabetes space, and to really understand the cell-cell interactions in the liver, drivers of fibrosis progression in the body compartment better, we need those technologies. We got to understand which cells are moving in. If you could block the role of B cells in the liver doing hepatocarcinogenesis, if you could block that specifically without affecting other organs. So really that type of basic science is the academic justification to be there, because these academics are defining the targets and empowering drug developers, from my perspective, to hit those targets. And not every basic science model translates into clinics for its relevance, but I think it really helps us to move ahead. And leads nicely into that session, in the end that I briefly discussed, gene therapy, the mitochondrial uncoupling. If you understand the targets and the pathways better, you're able to drug them.
That was extremely eloquently said, and the point I was kind of trying to make, but not nearly as effectively as you just did. So why don't we go to wrap up for this conversation? Let's say Louise and Jörn and I will be back in a couple of minutes with Sven. But Hannes, any other impressions you wanted to share with us about the meeting?
I was going back to what you were saying about CVD risk. I agree with that. And we as hepatologists usually talk about that, everybody else has to be better at thinking about the liver, but we also have to be better at thinking about the other organs. So how do we do that? We are so siloed in medicine, and maybe it's time to start to develop something like metabolic clinics where these patients get a one-stop shop and can get a full evaluation of their metabolic state, including the liver, the kidneys, the heart, everything.
Well, it's interesting because you say that, because that's 2 weeks in a row. Veronica Miller made the comment last week in talking about Paris-NASH from a regulatory perspective that when you change the name of the disease, well, one of the questions Louise has asked forever is why don't we include MACE, for example, as an endpoint as compared to simply something, a reduction in MACE as an endpoint as compared to MACE as a side effect or safety issue to be avoided. Veronica's comment was when you change the name of the disease, who knows? That might become possible. Agencies might look at it differently.
Yeah, it's also probably possible to factor in this in a design where you use the sort of the win ratio. It's a pretty concept that they use a lot in cardiology. I don't think it has come to hepatology yet, but where you can have a hierarchy of outcomes and weigh those against each other to see if the patient is sort of a winner or a loser, depending on what treatment you get. So maybe that's something for future trials.
I just want to ask, these are basic science conferences. They're about the future developments, the potential drug targets. What can we take practically away from this conference to start to help our patients now? We have a problem now. Science takes a long time to get anywhere. But where are we now as the end of the SLD Summit in Prague about being able to put this into pathways to try and help our populations in the next couple of years?
Well, I agree, Louise. We might not have the perfect tools. We don't have the perfect diagnostic. We don't have the perfect prediction tools or any perfect treatment, but we have to do something today. So I think it's necessary that we, as a community, say that to our partners, like, okay, we don't have all the answers, but this is what we recommend you to do right now. And I think there is some tendency in the field to do that we are no longer debating, what do we want to recommend, but how do we recommend it and to whom should we recommend it, talk about for now. Let's, for instance, in the terms of diagnosing these patients at the right time. So let's get behind, for instance, the FIB4 recommendation. Do a FIB4. It's not perfect, but at least it's a start. And then when we have that infrastructure set up and we get referrals, we can optimize it. And that will also, if we see that we get a lot of false positives in, which we probably will do, that will be an even stronger incentive for us as a community to build better risk prediction tools. Sorry for the rant.
No, excellent, great thoughts. Hannes, one last question quickly. Are you going to be in Boston?
Yes, I will be in Boston.
Excellent. I look forward to seeing you there. Thanks for joining us today, my friend.
And now for the Season 4, Episode 42 Business Report.
Slava Ukraini, Heroyam Slava, glory to Ukraine, glory to heroes. I'm simply going to repeat one of my comments from last week. I cannot wrap my head around the idea that members of Congress are willing to shut down federal government, in part because they want to end U.S. aid to Ukraine, a democratic ally. Small d democratic ally. Now, there's still $5 billion unspent in the current budget dedicated to Ukraine, and we're delivering the Abrams tanks starting right about now, so that's a better thing and hopeful for the future. Slava Ukraini.
Next week, we are making our largest change to the podcast format since the end of 2020.
Listening to our coverage of the EASL Congress, Paris NASH, and the SLD Summit, one of the breathtaking takeaways I had is the proliferation of research and research targets over the last year. This topic is a central point in our interviews with Sven and Hans this week. Now, we don't have any more budget than we did, but we've got far more items to discuss, so here's how we plan to attack that. Starting next week, we will intersperse weeks of one-on-one interviews with weeks of more traditional NASH Tsunami episodes. During the interview weeks, Jörn, Louise, and I will do one-on-one or maybe one-on-two interviews with individuals we find interesting based on what they do, what they believe, or what they've published. It will allow us to go into greater detail with segments we've not spoken to before, notably including payers and health system consultants, and to do one-on-one interviews with folks right after their publications drop. In the new format, on the interview weeks, we will announce on Mondays who our interviews that week will be, and then release the interviews through the week and over the weekend. We will work with this plan at least through the end of the year, and then test how you feel about it starting next year and modify it again if necessary.
This week's Volve conversation comes from last year's NAFLD Summit.
This week's Vault, episode 46.2 from Season 3, comes from last year's Summit. And take a listen. That's it for this week. I want to thank our team, Jörn, Louise, Jake, Mike, Eric, and Steve, for their work on this week and the upcoming transition. I want to thank Hannes and Sven for their exceptional interviews. Next week's our first interview week. Keep an eye out Monday or Tuesday for who I'll be interviewing. I don't think I'm the only one doing it next week. Until then, stay safe, surf on. See you again on the podcast. Bye-bye now.
Have any questions for the surfers? You can send them to surfingnash.com, and we will answer on the podcast or the website.